and it carries a 58% mortality. While if you look at the minor PE, and these are the majority of patients, the mortality is low, they have good prognosis, but please focus on the submassive PE population. That's 40% of PE population, so we're not talking about a small percentage. And these have, based on different studies, up to 20% mortality at 3 months. While these patients are typically treated, the minor PE typically treated with heparin or anticoagulation and sent home. Typically, patients with massive PE are thought of being treated very aggressively with lytics and other modalities. Most of the patients with submassive PE are usually treated with heparin. We're going to argue that maybe this population with submassive PE needs to be treated more aggressively to have a better outcome. Let me give an example of a case. This is a 22-year-old female whose status post C-section. She had chest pain for 3 days. If you look at her vitals, they look good. Good saturation, good blood pressure, good heart rate. The D-dimer is elevated, expected in patients with PE, but she has normal troponin and normal BNP, and the EKG was normal. If you look at the CT scan of this lady, you see the pulmonary artery here in the middle. This is the right pulmonary artery, the left pulmonary artery. They look clean, but if you scroll down on the screen, you will see a small filling defect. That's her pulmonary embolus. That's a small pulmonary embolus. Look at the right ventricle for orientation. This is the heart in the middle. The chamber on top is the right ventricle, and the chamber in the bottom is the left ventricle. Notice that the right ventricle is much smaller than the left ventricle, which is what we expect to see. So this lady has a low-risk pulmonary embolism. You may argue that you could put her on either heparin or low molecular weight heparin, or send her home even on Lovenox or on the new anticoagulants. Now contrast that to a 50-year-old man with no prior history except for smoking, who came with, again, chest pain and also some dyspnea. Look at his blood pressure, a little borderline, but does not meet criterion for massive PE. Heart rate elevated, which is not a very good sign. Oxygen saturation 92%. We typically are taught that patients with PE come with desaturation. Not always. Most of the time, patients come with saturation on room air above 90%, and they can be very sick. And these patients do not many times die from hypoxemia. They die from circulatory arrest, from blocking the flow from the right ventricle into the pulmonary arteries. Now, this guy, EKG, he has sinus tachycardia, some non-specific changes. His troponin is elevated. That's not a very good sign. BNP elevated. On an echo, he had moderately enlarged right ventricle, and this is his CT scan. As opposed to the lady that we presented earlier, his main PA is clear again. This is the right PA, left PA, and you can notice that there are a lot of filling defects in the proximal pulmonary artery branches. You can see him extending here into the other branches. You can see him going down into the segmental branches. And if you look at his right ventricle, although it is not very big, but it's as big, and that's the bright chamber, is as big as the left ventricle. So that's an enlarged right ventricle. And I want to argue that this gentleman should not be treated the same way as that lady who came in with very small pulmonary embolus, although in reality, both of these patients are treated about the same in real life. Now, why is RV dysfunction a bad thing? Now, I'm not going to present all the studies done on that, but I'm going to summarize them. There has been a lot of studies that showed that patients with RV enlargement do not do very well and have they have a worse outcome than patients with normal RV. There has been studies showing that if you look at RV to LV ratio, if that's more than 0.9 by CT scan, that's associated with higher in-hospital mortality. There are other studies, multiple of them, showing that RV hypokinesis by echo is associated with higher 3-month mortality. But also we know we're not just talking about mortality. We know that one of the dreaded long-term effects of pulmonary emboli, large pulmonary emboli, is the development of chronic thromboembolic pulmonary disease or chronic pulmonary hypertension. And although most of the time patients do well long-term, some patients, in some studies down to 5%, but probably in the submassive and massive category, up to 10% of patients may have chronic pulmonary hypertension after that. And if we have persistent RV hypokinesis at discharge, that's associated with higher incidence of future pulmonary hypertension and symptom limitation. And there are multiple studies showing these things. So this is why we like to be more aggressive, and we like to keep a closer eye on patients who show evidence of right ventricular dysfunction. How do we treat pulmonary embolism? So I'm going to step back and say, what are the available options for us? Number one, and the cornerstone, obviously, is anticoagulation. We could try systemic thrombolysis, and I'm going to go through these later in details, but just as a summary of everything available, we have surgical embolectomy, where Dr. Latouf is the national expert. We have catheter-directed therapies. We could use catheters using lower thrombolytic dose. We could do mechanical catheter. We have adjunct therapies, IVC filter, putting patients on ECMO, bypass. A lot of options available, and there's no very clear guidelines as to which one to choose. So let's keep going and talking about different treatments. So we talked about anticoagulation, which is the cornerstone of PE. So no matter what treatment option we choose, whether we choose lytics on very high-risk patients, whether we choose surgery, the patients has to be anticoagulation. They're going to be anticoagulated for a specific period of time. So the traditional anticoagulation is either heparin or low molecular weight heparin that are activators of antithrombin 3 that inhibits factor 10A and the thrombin. And this is an indirect inhibition of the coagulation cascade. Now, then the patients are started on warfarin, which is started after an overlap with heparin until levels are therapeutic. And warfarin is vitamin K antagonist, so decreases the formation of these coagulation factors. Now, we have newer agents that we can choose from, we can use. And these are the alternative oral anticoagulants, the new oral anticoagulants. And so far on the market, we have 4. The first 3, rivaroxaban, apixaban, and edoxaban, they're direct factor 10A inhibitors. So as opposed to heparin and warfarin, which are indirect inhibitors of factors, these medications are direct inhibitors of factor 10A, and dabigatran is a direct inhibitor of thrombin, which is factor 2A. And as these are direct inhibitors, they're more predictable, and the dosage is the same for all patients. You do not have to adjust the dosage. I'll come back to mention these a little bit later. But let's keep going about what other options we have, and I'm going to focus on what the indications in the next several minutes, what the indication for thrombolysis. So thrombolysis, and one of the common factors used is TPA, tissue plasminogen activator, and the audience is probably also familiar with other agents like streptokinase or urokinase that are uncommonly used now. And the other agent is TNK, tenecteplase, that's commonly used in myocardial infarction. In PE, we frequently use TPA, and this is a factor that activates plasminogen into plasmin, and plasmin degrades the fibrin into fibrin degradation products. What's the problem with thrombolysis? Obviously, is bleeding. We use it in massive PE, in very sick patients with severe hypotension, and maybe patients with high risk for submassive PE, and I'll go in details a little later about why and how we treat those. But we want to make sure there's absence of contraindications, and these are history of hemorrhagic stroke, or history of stroke in the last year, head trauma or brain surgery, intracranial neoplasm, recent internal bleeding, active bleeding, or recent major surgery. Now, so what do we know about systemic fibrinolysis? I'm going to talk about them in terms of guidelines. Now, again, the American Heart Association has tackled this issue and talked about systemic thrombolytics in patients with PE. And the guidelines give systemic thrombolysis in massive PE patients. So first, I'm going to talk about massive PE. Again, these are the patients that have hypotension. If you want to give them systemic thrombolytics, the guidelines do not give them class 1. Class 1 is something that's highly recommended. Class 2 is reasonable. So the guidelines say it's reasonable for patients with massive PE to be treated with systemic lytics if they have low risk for bleeding complications. And that's actually surprisingly based on very little data. There's one trial published in a long time ago, just on 8 patients. All 4 patients treated with heparin died, and all 4 patients treated with lytics survived. So based on this trial, which is obviously not a very robust trial, it became common sense to treat patients. It became common practice to treat patients with systemic lytics. Now, although this is not a good trial, there has been other studies, but not focused on patients with systemic lytics. So again, the data on systemic lytics in massive PE is not very robust, although we still use it. A meta-analysis suggests improved outcomes with thrombolysis in massive PE. So that's meta-analysis of multiple studies, including studies that included patients with less than massive PE. But if you look at the patients with massive PE in these studies, it seems that if you look at the composite outcome of recurrent PE or death, that's reduced with thrombolysis versus heparin. But the major bleeding, and that just makes sense, increases significantly with thrombolysis, so that if you just look at death, we have no proof that systemic lytics improve survival in patients with massive PE. We still use it because it's the best option available to us many times for these patients who only have an hour or two before they possibly die. Now, there's another registry, and this is not a randomized trial. This is not a very robust data, but there's a big registry on pulmonary embolism in massive PE, and it seems that retrospectively, if you look at the patient treated with thrombolysis, their mortality seems to be lower if they treated with thrombolytic therapy versus no thrombolytic therapy. It's a big number of patients, so maybe that gives us some idea that, yeah, maybe we're helping these patients. But out of this registry published by Stein, if you look at how many patients in real life are treated with systemic thrombolysis, only 30%. So there's 70% of patients with massive PE with a mortality rate of at least 50% that are just treated with anticoagulation for various reasons. There is a lot of contraindication for them. Maybe the physicians are not comfortable treating them with systemic lytics. And if you look at the same registry, and that's a sobering data, if you look at all the mortality over the last 20 years from these patients with massive PE treated with lytics, it really has not changed. Still around 20%. The whole population is about 50%, but the ones treated with lytics is about around 20% and has not really changed. And that's why we're trying to focus on this population and the high-risk population to see if we can, with new treatments, lessen that mortality, decrease that mortality. Now, we talked about systemic lytics in massive PE, the data behind it. What's the role of systemic thrombolysis in submassive PE? Again, these are the patients that have relatively normal blood pressure but have evidence of right ventricular dysfunction. They're at risk, they're at increased risk, but they don't look that bad right yet in front of you. They are at risk for deterioration. And the guidelines give it a class 2B, so it's a lower indication for these patients, and it says it may be considered for patients with submassive PE, judged to have clinical evidence of adverse prognosis, and obviously at low bleeding complication. And why is that? There has been more studies in the submassive population, and that's just logistic. It's easier to find and randomize patients with submassive PE that are more stable, and notice I'm saying more stable, they're not always very stable, that are more stable than patients with massive PE that are hypotensive, and they're bigger population. So patients, there is a study published in New England of Journal in 2002 called MAPIT3, and that's one of the first studies done in submassive PE patients, where they gave patients alteplase and heparin versus heparin alone, and they showed that the combined endpoint of death or escalation of treatment meaning they need further treatment or they need an addition of pressors, that outcome is better if you give patients heparin and alteplase, and these are submassive patients, but there was no difference in death rate. So that's about the same outcome that we found with maybe the massive patient population. More recently, there has been other studies too, but more recently, and the largest study on this subject was published in New England Journal last year. It's called the PIETHO Trial. There was 1,000 patients in this trial with PE and evidence of RV enlargement and increased troponin. These patients were treated with heparin plus TNK, which is another lytic, versus heparin alone. And they showed about the same outcome that has been shown before. So less hemodynamic collapse in the first 7 days, but similar mortality. Notice that there has been more strokes and more bleeding, obviously, with the TNK, 2.4 versus 0.2%. When they did a subgroup analysis, it seemed that the patients who are older than age 75 are the one who had most of these strokes. So what we gain from the study is that systemic lytics help these patients, but increase significantly risk of intracranial bleeding. But if you want to choose it, maybe choose it in somebody who's younger and definitely less risk for bleeding. There's another study. It's a smaller study, less quoted, but the importance of it is that they've used half a dose lytic. So the question is, if we can help these patients with a full dose lytic, what if we use half the dose lytics? The typical dose for TPA is 100 milligrams infused over 2 hours. So in this study, they infused 50 milligrams over 2 hours in patients with what they called moderate PE, which is a large PE, but patients were normotensive. And they randomized into heparin versus heparin and this TPA. What the importance from the study is that what they showed, although it's a very small study, 60 versus 60, the pulmonary hypertension at 28 months was significantly lower in patients treated aggressively with TPA. And that's another thing that I talked about earlier, why we want to be aggressive with these patients is we want to avoid this pulmonary hypertension down the road. Now, you can criticize the fact that the pulmonary hypertension incidence in this study was high, 56%, but the definition of pulmonary hypertension was very liberal. Any RV systolic pressure of more than any RV more than 40. There was a meta-analysis of lytics and PE showing that this is a meta-analysis published in JAMA last year, showing that if they looked at all the cases who were treated with lytics, they showed actually improvement in mortality, but then the major bleeding was significantly elevated. But if they focused on the patients who were younger than 65, then it looks like the number needed to treat is smaller than the number needed to harm. This is an example of a case who may be a good candidate for systemic lytics. 58-year-old man with history of hypertension. He came in with borderline blood pressure. So again, this blood pressure is not normal for this gentleman. So he's not massive, but he has high-risk features: new atrial fibrillation, increased troponin, severe RV enlargement. And if you look at his CT scan, the clots are a little more distal, and the RV is enlarged. This guy is a good candidate for systemic lytics. His pressure is borderline. He's a young guy, and this guy, we gave him systemic lytics, and he did very well. So the problem with systemic lytics, again, is major bleeding happens in up to 9% of patients, and up to 50% of patients have some contraindication to systemic lytics. So the question is, can we treat these patients that we want to give them the benefit of lytics without the side effect of it with catheter-directed therapy? So what's that? And the guidelines give that in massive PE a class 2A and in submassive PE a class 2B. So it says that it's reasonable to treat patients with submassive or massive PE with catheter-directed therapy if they are at increased risk and if there is expertise in the institution to treat them as such. There has been a meta-analysis of studies, and there's not a lot of good data on this treatment option either. The meta-analysis looking at a lot of patients treated with catheter-directed therapies showing that these patients have relatively reasonable outcome, clinical success rate of 86%. There was 2.4% major procedure complication, but most of that was due to a device called angiojet. This is why we don't use that in PE anymore. The rate of intracranial hemorrhage is very low, 0.1%. So our thought that maybe these patients can be helped with catheter with much lower risk of intracranial hemorrhage compared to systemic lytics. So what do we do with catheter-based therapy? We use a small catheter that goes either from the groin or the neck. It goes up to the lungs. We place it in the clot, and we infuse it. We infuse TPA at 1 milligram per hour, much lower dose than when we do with systemic lytics, 100 milligrams of TPA. And sometimes we use ultrasound facilitated infusion. That's a catheter that looks like this on X-ray. It's an infusion catheter in the clot. It has these markers that transmit ultrasound that helps loosen the fibrin clots and disseminate the TPA. There was one randomized trial done on this treatment. It's very small, only 50 patients. They gave him this catheter versus heparin alone, and they showed that the RV to LV ratio, which is a measure of how bad the right ventricle is, improved more with patients treated with this device called ECHOS versus patients treated only with heparin alone. So that's only a surrogate outcome. That's not clinical outcome of the patient. But if you look at the major bleeding, there was no incidence of any major bleeding in this population. Well, that's not true if you take a lot of patients. Some of them are going to have some major bleeding, but the risk is much lower than if you treat them with systemic thrombolytics. Was also a prospective registry of 150 patients using this device, showing that pre-procedure to post-procedure there has been significant drop in the pulmonary artery pressure, both at post-procedure and at 48 hours, with no intracranial bleed in this registry. We'll go back to the case 2 that I presented at the beginning of the talk, 50-year-old man who came in with borderline blood pressure, who I've told you that the RV was moderately enlarged, who I showed you those clots being in the main PA, and this patient we took to the cath lab and with the pulmonary angiogram, noticed the filling defects here in the right PA and the filling defects in the left PA, and we treated him with 2 catheters. This is one catheter in the left lung, this is one catheter in the right lung, and we monitored what happened to his PA pressure. Normal PA pressure systolic is less than 30, so at baseline he was 60. At 6 hours, it dropped very quickly to 40. At 9 hours, down to 32, which is unusual in PE. Just if you treat him with heparin, it takes up to 3 months for the clot to resolve on heparin. And the patient became symptomatically much better, and the catheters were removed after 12 hours of infusion. Where should I go? Now, this is another example. This is a saddle pulmonary embolus. So the guy I showed you had more distal clots. This is a saddle, big pulmonary embolus. And you can see that it's straddling straddling the pulmonary artery. This would be a good candidate, for example, for surgery, for an open embolectomy. This patient was not a good surgical candidate. She was older, she had HIV, and she has other issues that kind of precluded her from being a surgical candidate. We discussed her with our surgeons. And notice that RV, how huge it is, much bigger than the LV. It's compressing the left ventricle. And this lady we took to the cath lab. This is an angiogram. Notice that there's barely any flow in this pulmonary artery. Notice that there's a big filling defect here, the gray thing. You're supposed to see a big black filling here, and you're supposed to see the periphery of the lungs filling nicely, and all of that is blocked by this clot. And again, this is why we want to treat these patients. We want to help flow into the lungs before the right ventricle dies completely. We put a catheter in this lady, and then we brought her back to the lab. Notice that also we never get rid of the clots completely. This is before and this is after. The clots, they're still there, they're smaller, and notice the perfusion is much better, which is what we want to achieve acutely, is better perfusion. Notice here there's no perfusion in the upper lobe. There's good perfusion in the upper lobe and the lower lobes. So we achieved some improvement, although it was not extremely impressive, but at least we made the patient survive that acute event. Yeah. There are other treatment modalities. There are multiple catheters that we can use in the lungs. We can aspirate through new devices, venture devices. We can rotate catheters to macerate the clot. We can try to aspirate them. There is a big catheter called Angiovac that's very stiff. It's very hard to get to the lung. Dr. Latouf has experience with it. It's hard to get to the lungs because it is quite stiff. But all these are devices that may or may not help in the future as they get more developed to try to suck the clots out of the lungs. And obviously there's surgical embolectomy. I'm not going to go in details on it in this talk. Dr. Latouf has done a lot of these, and these are some of his examples. Notice how big that clot is in the lungs. This was supplied to me, I believe, by Dr. Latouf. This is a huge clot, and notice that it's best removed surgically if you can, if the patient is a good candidate, and if the clot is very proximal. I think we can stop here. I'm not going to go through IVC filters, but maybe we do another talk about further treatment of pulmonary embolism in the future, Dr. Latouf. We can talk about more of these things.
Yeah, let me say here, I consider myself to be an expert in the surgical management of pulmonary embolectomy, and I know this topic very well. However, I have learned a great deal from the presentation that Wissam you have given today. This is truly a classic presentation of pulmonary embolism. I love the slides that you have presented, the review of the literature, the images, the CT scans, the angiograms. Thank you very much for preparing just a terrific lecture. This topic is very important, particularly in the region of the Middle East. I became interested in pulmonary embolism when a dear friend of mine in Amman lost his 22-year-old daughter 2 days after she delivered her firstborn child. And I learned that the cause of that was a postpartum pulmonary embolism. Young women, the largest cause of death of young women is pulmonary embolism. And I wanted to address this topic and invite Dr. Jaber to speak, and then my colleague, Dr. Brent Keeling, will speak about our experience at Emory on the surgical management of pulmonary embolism. Having said that, let me put a personal statement here. I'm delighted that I've introduced to our audience around the world Dr. Wissam Jaber. 10 years from now, you will remember that I made the introduction to Dr. Jaber when he becomes an international authority and recognized as a leader in cardiovascular medicine. I want to open the time for any questions for the next 4 or 5 minutes while we have Dr. Jaber available before he goes to the cath lab. I'll start with Hebron University. Do you have any questions, our colleagues at Hebron?
I just want to, sure, I want to
Speak louder,
thank Dr. Jaber for this excellent presentation. Can you hear me?
If you speak louder,
can you hear me?
Go ahead.
Okay, I want to thank Dr. Jaber for this excellent. I want to thank Dr. Jaber for this excellent presentation. One of my colleagues has maybe 1 or 2 questions because I know you guys need to leave.
Please go ahead.
Okay, Doctor, thanks a lot. Okay, first of all, I would like to thank you for this fruitful lecture. Do you hear me?
Yeah, thank you very much.
Oh, okay, I have a couple of questions. The first, this disease, is it considered as inherited disease or acquired disease? And is there any gender or age differences? Does it depend on the aging process affect this disease, and which is more vulnerable to this disease, males or females?
Yeah, thank you very much for this question. This is a very important question, and I'm sorry we didn't have time to talk about all aspects of pulmonary embolism. I focused on management, but this is important. To answer the first question, most of the pulmonary emboli are actually acquired. They're either from post-surgical or post-long trip or post-medications. Some of them are inherited. Some of them are idiopathic. Some of them we don't understand why it happens. The patient does not have family history. But more than 90% of patients with pulmonary emboli do not have family history of necessarily pulmonary emboli and do not have an inherited, what we call thrombophilia. A minority of patients have inherited thrombophilia, like factor V Leiden or antithrombin 3 mutation and things like that. Now, PE tend to happen more in women, especially at a young age. Tends to happen more in women, but surprisingly, if it happens to men are more likely to recur. So, for example, if a woman has a PE, a first event, and a man has a first PE, that man is more likely to have a recurrent PE than the woman does. We don't know why. It may be hormonal. And I'm not sure. Any other question?
Yeah, I think.
I hope I answered your questions.
Any other questions?
We are fine here at Hebron. Thank you very much.
Yeah, you're welcome. Thank you for coming.
Specialty hospital.
Thank you.
Questions? Okay, if there are no further questions, I want to thank Dr. Wissam Jaber for an outstanding presentation. I hope you can share your slides with us. We will post them on our website. And thank you all who have participated on this webinar. Look forward to speak with you again in 2 weeks. Goodbye.
Thank you very much.
Thank you.
Bye-bye.